First of all, I welcome all the delegates on this CME. Recently, we have been ranked #1 hospital in Punjab. Anil Baghi Hospital is ranked #1 in Punjab, and it is awarded by National Health Authority and State Health Agency Punjab. The day before yesterday, another Fatarihat camp. ABH is among top 100 hospitals in India and among 6 hospitals in Punjab to receive the NADH accreditation for digital health standards. So this is a national level award that we got the day before yesterday. To help the patients, we have introduced My ABH patient portal, where the patient can book and manage their appointments and access their medical records online.
तो आवाज ही बढ़ा सकते हैं, आवाज बढ़ा, आवाज
So we'll just show you a small video.
थोड़ा आवाज बढ़ा दो, आवाज बढ़ाओ.
So now I invite Dr. Professor Amal Kanti Sen, very senior cardiologist. He will take his session.
Okay.
Thank you.
Okay, thank you very much. Now it's almost 1 hour, 8 to 9. I have eaten so much. Honestly, I'm feeling so sleepy. I'll finish it very fast, so I won't bore you. So just to briefly tell, we are doing around 50 interventions every month in Baghi, 50. You know, 50 is a big number because in most of the hospitals, even if you go to Chandigarh, one cardiologist does maximum 20 or 25. So, but we have, there's no hospital here, there's no cath lab here in this area. So we have a big, and then we do variety of mainly coronaries, PCIs, and stenting. Then we have pacemakers. Actually, last month we did 5 pacemakers. Then we have variety, we have ASD, VSD, PDA closures also, because I have a lot of training in that. And then we did a couple of CRTDs, biventricular pacing, we will show you. And luckily we got a case of carotid artery disease, and just 15 days back we did that, and the patient really did very well. So I will show you everything in very few minutes, won't take much of a time. Okay, so come. Okay, so this is a girl from Imphal. She had a huge ASD, almost 26 mm, that means 2.6 centimeter VASD, atrial septal defect. So next. So this is the ECG, typical RBB and typical pulmonary artery, typical ASD, X-ray and ECG. Next. And this is the, this is almost 2.5 centimeter ASD. This is the whole. Okay. This is the video. You see, just chala usko chala. See, this is the left ventricle small and the right ventricle double. Actually, the left ventricle is double than the right, but in ASD the right side is dilated. Now, just hold it. So now we are doing the ASD closure. Okay, we go from the right femoral vein, go to the right atrium, from right atrium we go to the left atrium, go to the pulmonary vein, and then we put the umbrella device in that and slowly open it, one part. So one part is in the right atrium, they pull it back, and then one umbrella is in the left atrium. One in the left atrium, one in the right atrium, and then we disconnect it. So I'll show you how. No. So we are going, you see, we are in the, just a minute, we are from the femoral vein, we are, come up to, this is the interatrial septum, and this is the device in a sheath. So we are just pushing it. Next. Go. So this is in the, this is the right atrium, and this is the left atrium. So we will open one umbrella here, we will open one umbrella here. So it's like that, just pull it back. So this is one umbrella, it will open, it will like a, it will make a picture like a fan, ceiling, that fan, table fan. Just come. See, now see. This is the umbrella in the left atrium. This is the umbrella in the right atrium, and see, bring that back, जो पहला था. Bring the, bus, hold. See, this is the atrial septum defect. This is the atrial septum defect. This is the umbrella in the right atrium, this is the left atrium. We have opened it and we have even, there is a detach, it's corrected here, and then you turn anti-clockwise, it gets detached. See? So it looks so nice. And then, we take it in different views. And see, this is the catheter. So, and it was here, we detach it. Okay, so next. Okay, now, and see this how it looks in the echo. See, we are doing it in the echo. Isko pass mein lage, just freeze. So this is, see now, this is interatrial septum. This is one part of the device, one umbrella. This is one umbrella. These two. So we have to check in the echo also that it's not moving. See, this is one part here, one part here. Okay, so this this ASD. See the advantage. See, she's a young girl, 22-year-old. If we don't do from the arterial, intra-arterial, and through the femoral vein and go into the left atrium, she will have to open her chest from here up to here, and anyway, see, the marriage and everything becomes a problem for them, because they think that it's a big surgery. And now, like this is just a matter of half an hour, and it's it's long lasting. She's completely normal. In just today we did it, and next 1 or 2 days she goes home. Suppose she does an open heart surgery, she will be there in the hospital 15 days. There will be a scar from here to here, and then it will be very difficult to hide for a marriageable girl. So it's a big advantage for anyone who is sort of unmarried. And even after that also, even if somebody is married, and it's very easy to do. Okay, so this is one ASD. Now next is we did a carotid angioplasty, which I was dreaming of doing it for last 10-15 years. We were doing it 15 years back, but there was a big problem because there was no embolic protection device. So we did it 1 or 2 cases, and the emboli went into the brain and produced hemiplegia, so we stopped doing that. But now we have embolic protection device. I'll show you. And we did the patient, and he did very, very bad. Patient came with left hemiparesis, and he had a carotid artery stenosis here. Alteplase was given. He became a little better, but still there was a huge stenosis. We opened it, and he did so well. He was not able to close his eyes, and his power was very less. But once after that, he was able to close his eyes. His power improved. So it's very, very good. Now see how it is done. Okay, just freeze, freeze. Okay, see, this is the common carotid artery. We again go from the right femoral. We came to the aortic arch, and this is the common carotid. This is the external carotid, and this is the internal carotid. Come. Chalo. Now we bring a sheath here, and then we'll put a wire here. Okay, go. Okay, just hold it. Go back, come back. Piche. Bas, just. See, you can't see the wire, but we put a wire here, and see this round. This is the embolic protection device. We are going to put a stent here, and this is the embolic protection device. So any debris, any clot, or any atheromatous plaque will get and stuck here. So it won't go to the brain, and it won't produce any hemiplegia or hemiparesis. Next. Okay, so this is the thing. Okay, next. Now we'll put a stent. See, hold. So now we have put a stent here, from here to here. You see, from here to here we have put a stent. Next. So you can see there is a stent from here to here. Then we inflate. So now we are inflating it. See, as you pull, it's self-expanding. So when you pull the inner catheter, it expands. So it has expanded. You see, from here to here. Okay, go down. Okay, now I think we took a picture. See the picture. Now you didn't see it before. It was not seen. Now you see a good vessel going up to that. We saw up to the brain. Next, but still we thought that this area is still narrow. So we put another balloon and dilated it further. Go. See, we put another balloon. It was 5 mm, and then we dilated it, and then the shape becomes better. Next, we dilated it. Go. See, we are dilating it. Okay, come up. And now see how big. So it is so gratifying, and the patient immediately became much better. Next day he was able to close his eyes. They were very happy. Okay. So this is carotid angioplasty. I think in whole this area, nobody did it. He went to Amritsar. They said no, not possible. Even he went to PGI Chandigarh. They were thinking how to do it, but somehow I don't know how he came here. And it has given us a lot of appreciation, prestige. Okay, next. Next. Okay, it's over. Next. Now, this is a very important patient, Rakesh Bali. Now, he came with acute anterior MI with BP 60, just 60 BP. And we did the angiogram, and he had complete almost 99% block of the left main. That meant the whole left system, LAD and LCX was blocked, and BP was 60. Just see. This right side was okay. Left, just hold. See the left side. See just at the opening of the left main, you can see it's a very dangerous angiogram. It's completely blocked here, and then but some flow is going on. And then we had no choice, because we didn't know that the condition is so bad and patient is in the cath lab and he is collapsing. What to do? If we don't do anything, he will definitely die. So we immediately put a wire here. Next. See, we put a wire here, immediately put a stent here and inflate, 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 inflate. Yes, see, we inflated stent, it's left main to LAD. We put a stent, left main to LAD. It's like a lot of, by experience, because there's no time to really put it properly. Only idea is to open the circulation so that he lives. And it worked, because immediately as we put the stent, his blood pressure came up to 100, 110, and immediately he became much better. See next. See the flow so good. Next. Actually, I showed this angioplasty recently in Medanta. All the great cardiologists were there. They were very impressed that it's like you really need courage to do this. You just 5 minutes you don't do it and patient is gone. Okay. Next. Now we did a CRT-D, this Manjeet calls. CRT-D means cardiac resynchronization therapy for cardiomyopathy, dilated cardiomyopathy, EF 30%. Once you have given the optimal medical management, digoxin, diuretic, ACE inhibitors, beta blockers, still the patient is not responding, then CRT, that means biventricular pacing is a big option, because the problem with this dilated cardiomyopathy with LBB, that the left ventricle contracts much after the right ventricle, so there is no synchrony. So by this, this CRT-D, we do a synchrony of the right ventricle and the left ventricle, they contract together. See, I'll show you how. Next. See, this is the, from left side, left subclavian. Go fast. Now, just hold it. Now, there is a one catheter, one lead in the right ventricle, one lead in the right atrium, and this is the very difficult. This part is very difficult, because we go from the coronary. This is the coronary sinus. We go into it, and then we have to find one cardiac vein on the back side. So this is the most difficult step. So this paces the left ventricle, this paces the right ventricle, and they both pace together, so that 120 millisecond gap is avoided, and when both the ventricles contract together, obviously the cardiac output, almost ejection fraction increased by 10%. Okay, come. Again, nobody in Firozpur is this area, nobody has done it. We have done 2-3 cases actually so far. And this is the generator. Next. Okay, so see, there's one lead. Come that. See, this is the RV lead. This is the left cardiac vein from the coronary sinus. It goes to the back side of the left ventricle. This is the front side, and there is one in the right atrium. So this is called CRT-D, and D means it's if there is a VTVF, it defibrillates also. So all the advantages. Only problem is that cost. It costs around 7-8 lakhs, but it's the ECIS, employees insurance, so that it is approved by that, so we can get the permission. Next. See that 3 leads, you can, whenever the 3 leads, you can understand it's a CRT-D. Now, this is a very interesting patient. Actually, I did it a couple of months back, and I have presented it maybe all over India. Even in the West, there was a big conference in Denver in the US. I presented it, and everybody this appreciation. Very difficult case, and I'll show you how. Next. See, just hold it. Okay, so a patient came with anterior MI, lesion in the LAD, lesion in the LCX. Okay, come, show. Okay, hold. So there was a block here, LAD. This is left LAD. So we just opened it, and it was it was done in maybe 5 minutes. So we were very happy. And then all the team, they said that there was a lesion in the LCX also. So they said we have finished in 5 minutes. Why not do the LCX also? Then we landed in problem. Come next. You see the LAD became very good. Next. This is the LCX. So we thought we'll do it. Next. So now see, we did it. We put the stent here, and then what happened, as soon as we put the stent here, and then she pulled her, we were doing with the radial, she pulled her hand like that. So everything came out, all the catheter, everything came out, and the patient collapsed. But anyway, we gave shock and revived, and then again engaged. Next. Aajo, dikhao. Hold. Next. No, इसके पहले. Before. Hold. Slow. All आगे slow. There is a dissection. He's not able to show it. Next. Hold. Before that. Hold. There was anyway, he's not able to stop it there. The patient, what happened when the patient lifted her arm up with the balloon, there's a dissection from here to here. The whole thing, intima came out. So there was no flow, and the patient, obviously arrested, and the BP fell, we gave shock and revived. And then the next option was a bifurcation angioplasty. So what we did next? No, before that. Before both that patient. Before that. Okay, hold. So we put two wires, one in the LCX, one in the LAD, and we put two balloons here. This is called bifurcation angioplasty of the left main, which is the most difficult angioplasty in the whole thing, and we inflated. Show. Next. Hold. This. See, this is in the LCX, this is in the left main. So we immediately put two stents there and came out, and patient really dramatically became very well, BP 120/80. Next. Now see the flow. The wires are there, one wire here, one wire here, and see the flow. So it's all in 5 minutes, in 5-7 minutes, because otherwise you can't save the patient. Next. Okay, and we followed her up, and she is very good. Another patient, this Sheetal Sarkar, he really created a lot of problem. Came with a simple LCX lesion, then we had to do RCA, then pacemaker. Just come show. Next. Go. There was simple lesion here, so we put a stent here. Go. Go. No. Okay, go. Go on, then see. There was a lesion here, left side, we put a stent. It was very simple, there was no problem. Go ahead. See, hold. See, this is stent. The first thing we do this, it was most simple, no problem. everything was okay, patient went home. Next. Next. Now come to the RCA. No, this was actually, PPI was later, PPI was the last, before that to show the RCA. Okay, this one. Go. Okay. So now after this LCX, patient came with acute right-sided myocardium, inferior wall MI. So now because of this right side lesion, so we put 2 wires and we were trying to stent because the whole thing was deceased. Now what happened, because it was so difficult when we were pushing the stent got lost here. The stent came out and uninflated, and again the patient collapsed, and we revived the patient, and then we crushed the patient, stent here and put 2 more stents here. So see, we put one stent here. Next, and we put another stent here. You see. So there was a stent here which we crushed to the wall. So I mean everything was okay. Okay, but his complete heart, he had complete heart block also. We thought because of right inferior wall MI, but even after stenting the inferior, right coronary, it didn't work. The complete heart block remained, so we put a pacemaker. Next. पेस में पहले वाला दिखाओ तो पेस में करो see, we did it from the right side. We paced. See, we did a DDD pacing in the right atrium. This is right ventricle. So this Sheetal, he gave a tough time. First we did a simple Lcx angioplasty, and then we wanted to do the right, but he came with an inferior wall MI with complete heart block. We did a right coronary angioplasty, but the stent dislodged. So it's very difficult situation if the stent dislodges without inflation. And we saw the stent, and we put a balloon and crushed it, and then put another stent. That was okay, but his heart block didn't go. His heart rate remained 20-25, and then we put a pacemaker. So luckily he was from the ECHS, something like army. So he could pay all the procedure. So these are, so we are doing variety of cases. We are doing pacemakers, we are doing CRTDs for heart failure, we are doing ASD, VSD closure, we did a carotid artery stenting, which was very thing, and then we are doing very difficult left main angioplasties, which actually people, even in Chandigarh and all, get afraid to see. They're thinking how you are doing in Firozpur. But anyway, God is great. He is helping us. Thank you. अरे वाह, चलो आजा.
So thank you very much, sir.
Okay.
Now I would like to invite our medical assistant Dr. What?
Plate, then plate. What is this?